So good afternoon, Professor Vũ Đăng Lưu, Professor Võ Tấn Đức, and esteemed colleagues. My name is Nguyễn Đức Sơn, and on behalf of our research team in Việt Đức Hospital, I am honored to present our research entitled Outcomes of Uterine Artery Embolization Prior to Pregnancy Termination in Cesarean Scar Pregnancy. So what is cesarean scar pregnancy? CSP for short is defined as the implantation of the gestational sac at a previous cesarean incision. If not diagnosed early and managed promptly, CSP can lead to life-threatening hemorrhage, uterine rupture, requiring hysterectomy, and serious consequences for both the patient's life and future fertility. So nowadays, there is a new management of this disease, and that is uterine artery embolization. So our research has two objectives. First is to describe the blood supply patterns of DSA and clinical outcomes of patients with CSP. And second is to evaluate whether residual myometrial thickness can be a prognostic factor for the need of uterine tamponade. We conducted a cross-sectional study consisted of 52 women diagnosed with CSP and treated with uterine artery embolization in Việt Đức Hospital, and later on received suction curettage in National Hospital of Obstetrics and Gynecology. And we analyzed pre and post embolization DSA findings, the rate of suction curettage success, intrauterine balloon tamponade, and hospital stay length. So first, let's go through some definition. So this is the blood supply pattern of CSP on DSA. According to Fengao and colleagues, the blood supply pattern is categorized into three grades. The grade 1 is the minimal blood flow type with only shallow gestational sac staining. The grade 2 is the moderate blood flow type with clear gestational sac staining. And grade 3 is the high vascularity type with significant patchy, large vessel on imaging, significantly faster blood flow, or a combination with uterine AVM. So this is a DSA images of a 26-year-old patient. As you can see, there is a CSP lesion with grade 3 vascularity. On image A and B, we can see is the selective angiography of the uterine artery. And images C and D is the post-embolization angiogram of the internal iliac arteries, showing no contrast enhancement of the CSP lesion. The next, we have the residual myometrium thickness, or RMT for short. So RMT is the thickness of the uterine muscle wall at the site of the previous cesarean section scar. It is believed that the thinner the scar, the higher the risk of the patient will develop complications like uterine rupture. Finally, we have the uterine balloon tamponade. So it is a device inserting into the uterus, and we inflate it to prevent and stop the postpartum hemorrhage. So moving on to the result section. On table 1 show the general characteristics of our patient. The mean age was 35.6 years old. Most of them had 1 to 2 cesarean delivery in the past. Time since last surgery averaged about 2 years, and mean gestational age was 7.5 weeks with a standard deviation of 1.3 weeks. On table 2, we have the clinical symptoms. Most of them were either asymptomatic, about 53.9%, or experienced painless vaginal bleeding, about 1/3 of the patients. Only 1/10 of them had abdominal pain with or without vaginal bleeding. So in the previous study by Rotas and Khoa, most of the patients either had vaginal bleeding or were asymptomatic. This shows that CSP has no specific clinical manifestation and leads to difficulty in diagnosis early. Next table illustrates a comparative analysis between 3 grades of blood supply patterns. Luckily, there was no major complication in all 52 patients. Gestational age and RMT did not significantly differ between groups. However, significant differences emerged into two critical areas. As you can see, 90% of grade 3 patients require uterine tamponade. This is substantially higher compared to 26.1% in grade 1 and 31.6% in grade 2. The p-value here is 0.002, indicating a highly significant differences. This led to a grade 3 patient had a median hospital stay of 3 days with interquartile range from 2 to 3 days, nearly triple that of grade 1 and 2. So this table shows that the grade 3 blood supply pattern is associated with greater clinical intervention and require longer hospitalization time. In this slide, we analyze the differences between two groups of patients, those who require uterine balloon tamponade and those who did not. I want you to focus on the residual myometrium thickness. The patient who required tamponade had a significantly thinner RMT compared to those who did not. The difference was statistically significant with a p-value of 0.047. With this result, we want to see that if there are any cutoff value, that if the RMT is below that, the patient will have a higher chance of requiring uterine tamponade in the future. So we perform a ROC curve analysis using RMT value. The area under the curve was 0.652, indicating a more discriminative ability. Using ROC analysis, we also identified the optimal cutoff was 2.05 millimeter. So patients with an RMT thinner than this threshold had a higher likelihood of requiring uterine tamponade during suction curettage. What's interesting is that our study is consistent with previous findings, showing that patients with an RMT equal or less than 2 millimeters are more likely to experience poorer outcomes compared to those with thicker scars. So in conclusion, cesarean scar pregnancy is often difficult to diagnose due to non-specific symptoms. Our study shows that vascularity rating on DSA, especially grade 3, is useful in predicting the need for uterine tamponade. We also found that patients with an RMT of 2.05 millimeter or less are more likely to require balloon tamponade after suction curettage. And finally, larger study with longer follow-up and proper controls are needed to validate this finding. This is my references, and thank you for your attention. I'll be happy to take any questions.